All right, guys. All right, guys. So this one is the part 3 in the cardiovascular system. So with this one, we already talked about in part 1, we talk about the heart. In part 2, we talk about the vessel and the circulation. And with this one, the part 3, we will start to talk about how our body regulate all these functions. So this is very much an autonomic regulation. And as you should know that our body autonomic regulation basically is achieved through two major mechanisms. One is the hormone, so hormone releasing and acts on the different organ system. And that's a way that our body respond to the to regulate or to maintain an homeostasis. The other one is the autonomic nervous system, and that nervous system is more directly send the neuron, send the neurotransmitter to act on different organ systems. So that's basically two pathways that our body regulates our body's function. All right, so we will talk about the regulation, and then we will also talk about the blood pressure. Blood pressure is a combination of both heart function and the vessel response. So, and the hypertension is so critical in our society. So we will talk about it. So here is again showing you that a very simple version of the cardiovascular system. We have the heart, we have the vessel. And I want to show the one thing I want you to get attention here is that when we have the blood from the heart, this oxygenized blood going to different organ system, the regulation of the blood to each organ system is controlled locally. It means that when you use your muscle, when you are exercising, say this is your, here we don't have the muscle here. Say muscle here. You use your muscle. When you use your muscle need more blood because your muscle burn more oxygen. It requires the oxygen to generate the ATP. And your blood to provide that local area will be increased. So that blood regulation to local region is regulated locally. So that's one very important concept you should know. But the question is, how is this achieved, the local regulation? So the concept is very much like our water system. So when you need water, it's not like whole building will have more water. It's only that faucet will have more water coming out of that pipe. So that faucet, that control of the water to provide a local need is controlled locally, okay? So the in that local region, that local needs, basically it's a local area that's very complex network of the blood supply. In this region, in this local region, we basically is the region that we have the substance exchange. It's a region that the oxygen will be delivered, CO2 will be delivered, nutrients will be delivered. Okay, so this is the region that is typically called a microcirculation. So this is in addition to the systemic and the pulmonary circulation. In this local area, we have a we have way to describe that local circulation called microcirculation. So this microcirculation, what's unique about it? So this microcirculation is unique in the way that its blood flow is regulated locally. So let's take a look at this sort of microcirculation. We have the blood from the oxygenized blood through the smallest arteriole, and then blood go into the capillary, and the capillary is a region that the substance have the chance to be exchanged, because the capillary has only single layer of the of the vessel wall. And then the blood, after the oxygen is delivered, they will carry the metabolic waste product. The major one is the CO2, go back to the vein and go back to the heart. So what's unique portion is that you can see that here we have a lot of, for example, sphincter. Sphincter is one, not only, but one of the mechanisms to control the blood flow. So when we need more blood, when this region needs more blood, this sphincter, this smooth muscle will be relaxed. I mean, it's not the only, it's because that the vessel, the arteriole also contains the smooth muscle. So this arteriole will also be relaxed. And altogether, this relaxation will open up this pipe and to allow more blood to go into this region and go into this network. So say if you are running, right, you are exercising, you want to have more oxygen coming here. You want to have more glucose coming here. The way you do it is, the way our body to achieve that need is to relax all this muscle and to allow a vessel dilation. And that will allow this fresh blood coming into this area, right? And this is very interesting that not just in the muscle is a place that we very like familiar day-to-day life, we feel that. For example, in the brain too, like if you are reading, the reading portion of the brain will also have the vasodilation, and that local region will have more blood poured into that region, that area. Say you are moving, the motor cortex in your brain will also be require more blood, and that local region will also have more blood flow going to that area. And that is the basis for the foundation for the functional neuroimaging that we can non-invasively to detect the function of the brain, because we will simply detect that the blood flow, then we will know which region in the brain respond to this specific task, say thinking, say reading, say language center, say smelling, say visual. So different task will activate different region of the brain, and we will have increased amount of blood flow to that local area. So that is local control in the muscle, in the GI system, in the brain, everywhere in the blood, in the body, wherever we have the microcirculation, we have this very unique local control of the blood flow. This local control of the blood flow can be very dynamic. As we mentioned before, that when you don't use your brain, your brain still requires blood, because it needs it to maintain the survival of the cells. Cells need oxygen, need glucose. But if you don't read, if you don't have visual, those local area will very quickly return back to the normal state. If you don't use your muscle, the vasodilation will turn back to the normal state. If you use it, it increase. So that response is very dynamic. And that's also a mechanism to support why do we need a warming up before the exercise. It's because that we need to, before we really use our muscle for a long period of time, we need to kind of open up the dilation of the blood vessel. And the way to do that is to have some warm up exercise. And that will prepare our vessel to be a little bit dilated to provide the blood needed for the real like a competition or like a exercise. So that's acute response, local control. We also, the local control can also have long-term effects. That if the region of the organ require the blood supplied for a long period of time, then not just the dilation is local acute response. Our body will also generate more vessels, more vessels, more microcirculation to that local area. So this is very typical, like, for example, the tumor, when tumor grows, they grow very quickly, and to provide that local needs of the blood, our body will have very quickly respond to the is so-called angiogenesis that provide the blood, provide a new vessel to neutralize this area. And that is the response, takes days, months, or even years to have that local long-term changes. So we have the acute response and the chronic response to locally control the blood supply. Now, what is the mechanism for this to be happening? The mechanism for acute control, we will only talk about the acute control here. For the chronic control is a little more complicated. So we are not putting it here, but local control you need to know. The acute control you really need to know. The acute control here is that how does our local vessel knows it needs to be dilated in order to provide more blood supply. There are two theories. One is called vasodilator theory. This theory states that explain this mechanism that when we use our muscle or when we use that tissues, we basically generate more metabolic waste products, such as adenosine, which is the breakdown of the ATP, carbon dioxide, CO2, right? And it could be more acidic, so it could be more hydrogen ions. And all these are known to be vasodilator. They can act on the vessel to make this smooth muscle to be relaxed and to open up the blood vessel. And so with this theory, it will make sense that if we use more, and when we use our tissue, it generates these metabolic waste products, and that molecules will then act on the vessel to cause vasodilation. So that's the vasodilator theory. The other theory is the oxygen demand theory. This theory is that when we use our muscle, right, when we use our local tissue, we basically burn more oxygen because the tissue needs oxygen to generate ATP. And then because the oxygen is is we only have this amount of the oxygen locally. So when oxygen is used by the tissue, smooth muscle in the vessel will also require oxygen to provide the vessel, to provide the contraction, right? Muscle contraction needs ATP, as we learned before in the skeletal muscle portion, that we know that the myosin acting, binding, causing this muscle contraction, that require ATP. And the ATP synthesis require oxygen. So if all the oxygen in that local area is used by the tissue, but there will be less remaining for the blood vessel. And that will make the blood vessel, make the smooth muscle not able to contract that much. And that will make the vessel become relaxed and causing the vasodilation. So that's two theory. And both works, both make sense. And both, not just a theory, so many data support that these two could be to be very effectively to trigger a vasodilation locally. In addition to that, another mechanism is also very important. That is the nitric oxide, NO. So NO is a very important molecule in our body to maintain the vessel health. Healthy endothelium, when there is more blood flow into that region due to the increase of blood flow and due to the needs of the blood supply, that increase of blood flow will first act on the endothelium cells in the very inner layer of the vessel wall. And that will trigger that endothelium cell to synthesize NO. In the endothelium cell, we have the enzyme called eNOS, endothelial-derived nitric oxide synthesis, eNOS enzyme. So this eNOS enzyme, when it's activated, when the vessel endothelium cell is activated by that shear force of the blood flow, will release NO. NO then acts on the smooth muscle to cause vasodilation. So when you have increase of the blood flow, that will also cause the endothelium cell to release NO to make the vessel become even bigger to accommodate the incoming blood flow. So here is the very like a typical drawing of the relationship of the endothelium cell and the smooth muscle. So endothelium cell is in the very inner portion of the blood vessel. This is the blood, and when the blood flow increase, that will act on the endothelium cell. Endothelium cell has a receptor to detect that mechanical force, and that will activate the enzyme in the cell, and that is epithelial-derived NO synthesis, eNOS. Then eNOS will convert the O2 and L-arginine to form NO. Then this NO is the gas, as you know, and it's not like the gas can sustain with NO only as an NO for a long time. They can only be NO for a very short period of time, then they'll be degraded. That make it only able to act on the local, the neighboring smooth muscle, and they will diffuse around, and when they diffuse to the, besides this is the gas, so they can penetrate to cells. They can go through the cell membrane because this is lipid soluble. to act on the smooth muscle to cause the muscle relaxation. So nitric oxide, NO, is a vasodilator. This probably is the key though. I mean, in terms of the exam, you will see a list of molecule, and the question would be, which one is a vasodilator? Because earlier we talked about some metabolic waste products. Those are also very active vasodilator. And with this one, nitric oxide is also have the capacity to cause vasodilation. And so nitric oxide, NO, is a vasodilator. In addition to that, if the endothelium cell is injured, or if the vessel is injured, it will increase its release of a different type of the molecule. This is endothelium. This endothelium, in contrast to NO, endothelium can cause vasoconstriction. So this is this is vasoconstrictor, okay? So if I have a list, which one is the vasoconstrictor? Endothelium is the one, okay? So when we have the injured, damaged vessel, it will release, the endothelium cell will release endothelium to make it vasoconstriction. The idea is that if the vessel is injured, right, you want to prevent the bleeding. And so you want to make it constrict to reduce the blood flow. And this can also become an issue when the patients have not bleeding, but perhaps hypertension, right? Because hypertension, or in the diabetes patient, that endothelium cells experience for a long time experience this high pressure or the hyperglycemia for a long time, and that alter the cells, and to make this cell become abnormal, and then this abnormal cell may release more endothelium. This endothelium then acts on the vessel to make it become vasoconstriction, and that make the vessel become more rigid. In a condition of hypertension or diabetes, this will make the condition even worse, because now you have the rigid vessel. You don't have the very elastic vessel. You have the rigid vessel, and that make the patients, generate a different type of more like a complicated issue with this original disease. So that is how our body regulates the blood flow locally, okay? Globally, it will be something like the blood pressure, okay? Increase of the blood. Globally will be like increase of heart rate, increase of the heart contractile, or global increase of vasodilation or constriction. And that is relevant in a way that it affects our blood pressure. So let's look at what is blood pressure. We have this taking this blood pressure when we see doctor all the time. So this is not anything new to us. But what's the physiological mechanism behind it? And that's something we are going to learn today. So blood pressure. One thing you need to know is that the blood pressure in our body vary depending on the location. So in the heart, the blood pressure vary from around zero to about 120 in the healthy patient, in healthy person. But in the aorta, in the artery, the range become 120 to about 80. So the highest one is called the systolic pressure. The lowest one is diastolic pressure. When we measure the pressure, though, we measure the large artery that's around the arm, and that's very similar to the one we can get from the aorta. So in normal subjects or normal person, the range is the pressure with 120 to 80. So that's normal range. But you need to know that even though it's normal range, I mean, about a third of our population, adults, are categorized as hypertension. So here is the chart from American Heart Association. I think this one is released in 2017. So if it's 120 and 80, it's considered as normal. If it's 130, more than 120, then it's considered elevated. If it's 130 to 139, it's considered as the hypertension, okay? Stage 1, 2, and even higher. So that is the range that we need to, that is the number that you as a healthcare giver, like working to take care of the patient, you need to have this number in mind, that 120 or lower, 120, 80 is okay, but 130, 80 will consider stage 1 hypertension. Now, okay, so hypertension affects about a third of our population. One thing you need to know is that hypertension just by itself doesn't really make a person feel any sickness, okay? And that is an issue because the condition will be with person, but the person don't feel the need to take care of it. And so a lot of the patients, they don't know they have hypertension, and they, even if they know, they don't really pay attention on the management to take care of this condition because they don't really feel the needs. It doesn't immediately cause you feel sick or anything, and that is an issue. So what is the blood pressure? The blood pressure, we can break down the blood pressure to two major factors. One is the cardiac output. The other one is the total peripheral resistance. And so you need to know this equation. BP, the blood pressure, equal CO, cardiac output, times TPR, total peripheral resistance. So when we talk about the hypertension, why is that difficult to really pinpoint the cause of the hypertension? It's because that it could be the high CO, it could be the high TPR. You know, it really depends on, it really individually dependent. That the condition to cause this person's hypertension is very likely to be different from the reason to cause the other person's hypertension. So there's no single pill to treat hypertension. It would require a lot of investigation to see what is the true cause of a person's hypertension. It could be the CO, it could be the TPR. About CO though, cardiac output equals stroke volume times heart rate. So a simple increase of the stroke volume, more of the blood output, cardiac output, or a simple increase of the heart rate. The increased heart rate could be the nervous, right? The stress life could also lead to the increase of the CO. So these two equations are very important. CO equal SV times HR. This one we already talked about when we talk about the heart. This one is new though, new here. That you probably learned this already, but I want you to keep in mind that this one is very important. BP equal CO times TPR. It's also a quiz question, okay? So you will see this one in the exam. So let's see that this is a table on the chart from the textbook that the blood pressure, the mean arterial blood pressure is determined by, here is a list. Let's take a look at this list. It may first seem very complicated, but breaking it down, it basically is these two factors, CO or TPR. Increase CO, increase blood pressure, increase TPR, increase blood pressure. CO equals stroke volume times heart rate. Increase stroke volume, increase heart rate will increase CO, and the increased CO will increase BP, increase blood pressure. So let's take a look. So mean arterial blood pressure is affected by the blood volume. So that is determined by the fluid intakes. Okay, so drinking too much of the water could be, but usually it's not that. Usually it's the high salt diet. It's because that if the person eats high salt diet for a long period of time, then the body has more sodium. That sodium will keep more fluid in our body. Just by drinking water, you basically just pee out. So it doesn't really remain in the body. But eating high salt diet is different because high salt diet will make our blood more sodium solution, and that will keep our urine to be retained in our body. And that is the major reason to cause the fluid retention in our body. Fluid loss, this one could be the bleeding or swelling. That's losing the fluid, and that decrease the shock volume, and that decrease the BP. So blood volume. The other one could be the heart pump, heart rate, or shock volume. That's right here. So this one could be the stress life, right? If you have a very stressed life that you need to be ready for task after the other task, and you need to be very alert all the time, then your sympathetic nerve is activated. That will act on the heart to make your heart rate pump faster, and that will increase the cardiac output, increase BP. And this one is the resistance of the system to blood flow. So this is the total peripheral resistance, right? The diameter of the artery. If it's narrowing, then, for example, the injured endothelium cells will cause the epithelium cell to release the epithelium, then that will cause vasoconstriction, and that vasoconstriction will increase TPR. And also the diameter of the vein. Again, this one is also related to the total peripheral resistance. And that is, for example, if you probably have seen this before, but to me, it happens a lot of times that when I get to take my blood pressure, they will ask me not to cross my legs, right? Why not to cross my leg? It's because that if you cross your leg, you kind of squeeze your vessel. You squeeze your vessel, especially in the leg, we have a lot of veins there. If you squeeze your veins, then you basically increase your total peripheral resistance. And that causes the increase of the blood pressure. So even though it may first seem complicated that the cause of the blood pressure change can be complicated, but breaking it down, it basically these two factors, CO and TPR. It's about the heart and it's about the vessel. Another thing you need to also know is that because all these blood supply to tissue organ are connected in parallel, amputation or surgical removal of an organ will increase the TPR and cause the blood pressure increase, okay? So the idea is that, say, this is the Costco gas station, that you have a line here. And so say this is a blood vessel parallelly connect to each other. And if you happens to see that one pump is broken, then you have you have to remove one lane. You have the last lane here. Then you will see more resistance of the car to go through it, because you lose one more lane to pass through. And so more lane you have, the flow will be easier. The less lane you have, the flow will be harder. And so amputation will cause the increase of TPR and to increase the blood pressure. So that is the concept about the blood pressure. Now, let's look at how do we regulate our body's blood circulation, blood pressure, etc. The way we affect our body, the systemic change or systemic regulation is by two mechanisms. One is the autonomic nervous system, the other one is hormone. So let's start by looking at the autonomic nervous system. So just before we jump into the autonomic nervous system, I want to give you a global view, the bigger picture about the nervous system. So here is the diagram, the branch of the nervous system. We basically has in the nervous system, we have two branches. One is the central nervous system, CNS, central nervous system. This one includes brain and the spinal cord. And then we have the peripheral nervous system. Peripheral nervous system is the nerve that interface with the outside world. That interface with the, not just the outside world, but outside of the nervous system, okay? So it interfaces with other organ system. That interface basically can be broken down to two types of interface. One is the sensory, because we need to be able to detect everything around us. And that signal will then send to the central nervous system to process it, to make sense of it. So that sensory portion is the part of the peripheral that get any information around our body, seeing, feeling, tasting, hearing, or in our inside of our body, like the amount of the blood pressure change, the amounts of the CO2 level. We have the mechanoreceptor, the baroreceptor, the sensor to detect that environment, that information, and get it through the peripheral, then sent to our brain to make sense of it. That making sense may not be voluntary. It could be the autonomic, like to respond to it, to regulate our blood pressure or to regulate our breath pattern. So one part of the branch of the peripheral nervous system is the sensory. The other interface of the nerve to our non-nerve organ is the motor, because now we need to be able to control our muscle. For example, if you are thirsty, you will need to grab a bottle to drink it, and that grabbing is to control your muscle. And so that interface is the nerve to the skeletal muscle. We also need to regulate to control our heart rate, to control our smooth muscle, to control our cardiomyocytes. That control is also an interface of nerve and the non-nerve organ. And that control is through, so we can have a motor have two branches. One is called somatic nervous system or the voluntary nervous system or skeletal motor nervous system. This one is more like a control of the skeletal muscle. Through the neuromuscular junction, it releases acetylcholine binds on nicotinic acetylcholine receptor to cause muscle constriction. The other one is called autonomic. This one is not by your voluntary movement. This one is to control the two other type muscle, the cardiomyocyte and also smooth muscle. So that part is the autonomic, and that's the one we are going to talk about today, the autonomic nervous system. Autonomic nervous system has two branches. One is called sympathetic nervous system, sympathetic. The other one is called parasympathetic. So basically our body has two modes. One is sympathetic, that is fight or flight. Parasympathetic is more resting and digestion. So, and during each mode, our autonomic nervous system will be performing differently. So this is two branches of the autonomic system, nervous system. We have the, if we are in the fight or flight mode, we activate the sympathetic nerve, and that will prepare our body to survive in the urgent condition. But we also need to have, if we don't have that urgent condition, our body will switch to the rest and digesting. The parasympathetic nerve will be activated. And at this moment, we will start to digest our food. It's time to enjoy the food, to eat the food, and also to prepare our body for the growth, for the development. So we have two modes. And these two modes affect our cardiovascular system. So here is the a simple summary of these two branches of the motor branch in the peripheral nervous system. So the motor could be the somatic nervous system, that we have the lower motor neuron acts on the skeletal muscle, release acetylcholine. So we learned this one already. This one is new today. So we have the another branch is autonomic nervous system. Autonomic nervous system also acts on the muscle. Here we act on the cardiomyocytes or the the smooth muscle. We have the sympathetic nerve and the parasympathetic nerve. In the sympathetic nerve, it releases the norepinephrine. NE is the norepinephrine right here. Norepinephrine to act on the heart, GI system, vessels. It also causes the adrenal glands, adrenal medulla to release epinephrine and norepinephrine into the blood. And that circulating in the blood serve as a hormone to act on the heart as well as on the vessel. So the sympathetic basically use two chemicals, norepinephrine and epinephrine, to cause the cardiovascular changes. We also have parasympathetic, it releases acetylcholine. So this acetylcholine is the same as this acetylcholine, but their function is different because the receptor is different. This one acts on the nicotinic acetylcholine receptor in the muscle. This one acts on a different type of the receptor in our GI system, in our heart and our vessel. So from this chart, I want you to memorize the neurotransmitter. The key here is the neurotransmitter. What is the neurotransmitter for sympathetic nerve to act on our heart and vessel? Epinephrine and norepinephrine. So these two are the answers. What's the neurotransmitter for the parasympathetic nerve to act on our organ? That is the acetylcholine. Okay, so I want you to memorize this. Also, in the skeletal muscle, we already learned this, that the neurotransmitter to act on the skeletal muscle is the acetylcholine. So how does it affect our cardiovascular system? So the major function is achieved by the sympathetic nervous system. So basically that when you are in the fight or flight mode, the norepinephrine and epinephrine will start to work. There are three major receptors, two major ones, and the third one is important but not as critical as the previous two. So it will act on the beta-1 receptor in the heart to cause the increase of the heart rate, increase the contractile. So it will make the HR higher to make the stroke volume larger. And in the end, we will have larger CO and to cause the larger BP. BP equals CO times TPR. So that's the beta-1 receptor. This epinephrine and norepinephrine can also act on the alpha-1 receptor in the vessel. This one will cause vasoconstriction. We commonly see this alpha-1 receptor in the skin vessel, abdominal, viscera, GI tracts, in the skin, and urinary bladder. And so this one, basically, if you are in the urgent situation, you don't need to work on digestion. So basically that you will cause vasoconstriction over there. And that will actually have effects on the blood pressure too, because increase the vasoconstriction will cause increase of the TPR, BP equals CO times TPR, your blood pressure increase. So you need to remember that beta-1 in the heart, alpha-1 will cause vasoconstriction in the vessels. They also have another effect, that is the beta-2. So it's different. In the to cause the bronchodilation and the vasodilation in the coronary artery. So why is that? Because when we are in the sympathetic mode, in the fight or flight, we basically need to breathe harder. We need more oxygen. So the function is achieved by acting on the beta-2 to cause bronchodilation. So your broncho dilate, you can breathe in more oxygen. You also dilate your coronary artery. This is the blood flow to the heart. Because now your heart is pumping faster, harder, you need more oxygen, more nutrients to supply your blood, your heart work. So you have vasodilation in the coronary artery, achieved by acting on the beta-2 receptor. So these three are the quiz question. Beta-1 in the heart, alpha-1 in the vessel cause vasoconstriction, beta-2 to cause the bronchodilation and the coronary artery dilation. So that's the thing you need to, you need to know from this lecture. And this is also related to our way our body manage the blood pressure homeostasis, the cardiovascular homeostasis. In our body, we basically trying to maintain the blood pressure in normal range. The way to do that is to have the blood pressure sensor. We need to be able to detect it in order to regulate it. The sensor is located in two major locations. One is in the air. This sensor is called the baroreceptor. The baroreceptor detects the blood pressure. They located in the aortic arch as well as the carotid sinus receptor here. When they detect the blood pressure change, they will then send signal into the brain and to trigger if the blood pressure is too low, then it will trigger the sympathetic nerve to release norepinephrine and epinephrine to return to increase the blood pressure to the normal range. So this is a very important feedback loop to maintain our blood pressure in a homeostatic level. And this is very important in a way that, for example, that when we lay down and suddenly gets up, a lot of time that suddenly gets up, or when you sit and stand up, a lot of time that affects the blood pressure a lot. The reason is that when you suddenly stand up, a lot of blood remain in the lower extremity, and so you don't have a lot of blood going back to your heart. You have less venous return, and less venous return means less stroke volume. Less stroke volume means less cardiac output. Less cardiac output means less blood pressure. And when you have that sudden decrease of the blood pressure, your brain don't have enough blood to go into the brain, so you may suddenly become dizzy, lose your consciousness. And that will make the person lose the balance and may fall. And this is the condition called the orthostatic hypotension, that the low blood pressure due to the sudden change of the posture. This happens in old people. It's because their autonomic nervous system is not as sensitive as the young people. For young people, this condition can be correct very quickly, that our baroreceptor detect the drop of the blood pressure, very quickly send signal to the brain, and to trigger the sympathetic nerve. Sympathetic nerve will start to act on the heart to make the heart pump faster. So even though we have less venous return due to the change of the posture, we increase the heart rate. So that way we can maintain the blood pressure and to prevent a sudden loss of the blood pressure. So that's the effects by the autonomic nervous system. The other portion to regulate our blood pressure is the hormone. The major hormone to regulate our blood pressure, in addition to the norepinephrine and epinephrine, that's considered hormone as well, but it's also largely regulated by our sympathetic. So in addition to those, angiotensin II is one major hormone to regulate our blood pressure. Angiotensin II has profound, has large, has very wide effects to increase blood pressure, because angiotensin, just by the name, you know that it's a tension. It increases it causes vasoconstriction. So this is one cause vasoconstriction, okay? If I have a list of the molecule that which one is vasodilator, which one is vasoconstrictor, angiotensin II is the vasoconstrictor. And that increases the TPR. And this is systemic throughout the entire body. And that basically will increase the blood pressure. It can also act on the kidney to cause sodium retention and water retention. Not directly, but indirectly, to cause our body to retain more water. And that retaining water basically will store in the vein. Venous return will increase the stroke volume and increase the cardiac output. So angiotensin II acts on these two. Directly acts on the increase of the TPR. Indirectly, it causes the increase of the cardiac output. And overall, you have CO increase, TPR increase, you have the blood pressure increase. So that is very powerful function of the angiotensin II. And that's the reason that when we have hypertension patients, we can treat the patient basically through several mechanisms to treat the hypertension. Very common one is the beta blocker. We block the beta-1 receptor to prevent the sympathetic nerve to act on the heart. But beta-1 receptor blockage is not good because it affects our autonomic nervous system, and the patient may have the orthostatic hypotension, that when our body need to have a baroreceptor feedback to control, to regulate our blood pressure, that will fail. So that's not a good option. Another option is to target this angiotensin II to prevent, to reduce the production of the angiotensin II. So how is angiotensin II released? What's the mechanism for angiotensin II to increase or decrease? So this leads to this very important pathway, renin-angiotensin II pathway. So this pathway may first seem complicated, but it's truly very important that you must know. Here is perhaps our first time talking about it. But later, when we talk about the renal system, we will talk about it again. So if we talk about it several times, I hope that even though this is new to you, you should be very familiar with this one. after taking this course, okay? Because this is truly very important. All right, so how is angiotensin 2 is released through this pathway, renin-angiotensin 2 pathway. So it starts by renin. What is renin? Renin is the hormone released from the kidney. So here we have the kidney. Kidney can be triggered by 3 mechanisms. One is the sympathetic that, fight or flight, the stress life. The other one is the low pressure, that if there's suddenly drop of the blood pressure, then you will force the kidney to release renin. The other one is the sodium. We will talk about this one in the distal tube. This one is in the nephron. So we will talk about this function when we talk about the urinary system. So let's just assume that you know this. But you should already know this too, like increased sympathetic, you know that the person is, in the urgent condition and it needs to trigger the sympathetic nerve, or dropped pressure, perhaps the person has very bad bleeding. Then it will trigger the kidney to release renin. Then the renin will convert angiotensinogen. Angiotensinogen is the hormone released from the liver. It flows in the blood. When it sees the renin, angiotensinogen will be converted to angiotensin 1, A1 here, angiotensin 1. Angiotensin 1 then flow around in the blood. When it flows into the pulmonary circulation, in that circulation, you see there is an enzyme called ACE, angiotensin conversion enzyme, ACE. This enzyme is located in the lung, in the pulmonary circulation, and in the epithelium cell. When the angiotensin 1 see that, it will be converted to angiotensin 2. So now we have the very powerful angiotensin 2. Angiotensin 2 can directly cause vasoconstriction because by the name angiotensin, you know that it's cause the tension, vasoconstriction. It also indirectly cause increase of the cardiac output. And the way it does is through these 2 pathways. First, angiotensin 2 will then act in the brain, flow to the brain. Brain have the pituitary gland. Pituitary gland will release, the posterior pituitary gland will release ADH, the anti-diuretic hormone. This one will, anti-diuretic means that it will reduce the urinary formation. It means that the ADH will act on the kidney to reduce the urine, and a lot of fluid will be retained in the body. So it will cause the water retention. And the more water in the body, more water in the vein, and the more water cause the venous return, then we have more stroke volume, we have more cardiac output. So this one increase the blood volume and the increased cardiac output. So that's the ADH. Angiotensin 2 also acts on the adrenal cortex. Adrenal cortex will release one important hormone called aldosterone, right here, ALDO, aldosterone. Aldosterone function is to regulate our salt, our sodium and the potassium. And the function is to act on the kidney to cause the sodium retention. And the more salt in our body will draw more water in our body. And that will also cause the cardiac output increase, cause more venous return, cause more cardiac output increase. So overall, angiotensin 2 directly acts on the vasoconstriction. Angiotensin 2 also indirectly increase the cardio output. And these two, CO, TPR, we have the increased blood pressure. Just a side note here, ACE, you probably heard this already. It's become so famous that the COVID-19, this virus, acts on our lung. It's now known that it actually can enter the lung. The reason is that it can bind on a type of ACE, I remember it's ACE2, that binds on it. And through that, to enter into our body. So that's, when you see this one, you know that ACE, the major function of the ACE is to convert the angiotensin 1 to angiotensin 2. So that's this pathway. And that's very important. And a lot of quiz questions can come from here. For example, what's the enzyme to convert angiotensin 1 to angiotensin 2, ACE? What's the enzyme to convert angiotensinogen to angiotensin 1? That's the renin. Where is renin released? Kidney. Where is ADH released? In the brain. Aldosterone, adrenal cortex. What's the function of ADH? To cause water retention. So already, you know, we probably talk about 20 questions here already. And you know that in the exam, we probably talk all the questions already, right? I still have not decided how many questions to be in the exam, but say 50 questions. You already know 20 questions here. All right, so just see this from a different angle. That here is the kidney. That's where we see the renin releasing. It basically is the place that is in the nephron. So here is the nephron. Nephron is the unit of the urinary system. Here we have the glomerula, and this one produce the urine. Urine's out, urine flow to here, and the pee out here. We will talk more about this one in the urinary system. The reason I bring this one up is that I want to show you that renin is produced in the kidney. So here again is the renin, the nephron, and here, okay, one more nephron picture. This is the nephron that through all these loops, urine is produced. And just very quickly, that this is the region that we have the ADH on it to cause the water retention. So if we have the ADH, the urine will be, before it pee out, it will be reabsorbed back to our body. Okay, only pure water. So don't worry that we reabsorb urine. We reabsorb the pure water back to our body. So those metabolic waste products will still be pee out. So don't worry that we reabsorb urine. We absorb the pure water here. So here you go. This is in the nephron, in the glomerular area. That's we have the juxtaglomerular cells. This is the cells to produce renin. Okay, so renin is produced from the kidney. What kidney? The cell is called juxtaglomerular cells. That is the cell to produce renin. And then renin through the renin-angiotensin 2 pathway to produce angiotensin 2. So that's the renin portion. ADH, renin angiotensin 2, can act on the brain. Which brain? Pituitary gland. Okay, so ADH is also called vasopressin. So ADH, we talk about the ADH as an antidiuretic hormone to reabsorb water. Itself, it can actually cause vasoconstriction as well, because its name vasopressin is function as a vasoconstriction. All right, so ADH is originally synthesized in the hypothalamus and released in the posterior pituitary gland. So it's in the brain. It went through two portions of the brain. It was originally produced, synthesized in the hypothalamus, and it got transported to the posterior pituitary gland, and then it released from posterior pituitary gland into the blood. And then it flow around, acts on the vessel as the vasopressin. It acts on the kidney to cause water retention, water reabsorption, pure water, not pee, okay, not urine. So but just by itself, it's a good blood pressure to cause blood pressure increase, because it can cause vasoconstriction to increase the TPR, to retain water, to cause venous return, and that will cause increase of the cardiac output. CO times TPR, BP increase. So that's the ADH. Give you a visual understanding. So here is the region of the brain. This region contains the hypothalamus up here and the pituitary down here. So ADH right here is synthesized in the hypothalamus, and it got transported down here to the pituitary through the axon transport. It's because this is neuron, the brain. And then here is the pituitary. Here it releases it into the blood. And then it will flow around, act on the vessel as well as on the kidney. So the ADH can be triggered by angiotensin 2, as we talked earlier. ADH is also an important regulator to regulate our the blood osmolarity. It means that if our blood becomes thick, like the osmolarity increase, right? Because say if you are walking in the desert and you sweat a lot, and so your blood lose a lot of fluid, so your blood become thick. Blood has high osmolarity. And then we have the sensor to detect, because we need to maintain a very stable osmolarity in the blood. The sensor is in the hypothalamus, in the brain. And that detects the blood, see that, oh, it's very thick. You have very thick blood. It means that you lose a lot of fluid. And it's very common that in our typical life, we don't really live nearby the river, right? So we are not like ocean animal. We are the land human. So so that high osmolarity detected by the hypothalamus will do two things. Okay, that first will tell ADH, will trigger the ADH to retain water, because now you lose a lot of water. You are in the land, you sweat, and you didn't drink a lot. And so you cannot. Water is precious, that you need to retain it, pure water. So ADH acts on the kidney to retain water. So that's one thing the brain will tell ADH to do. The next thing brain will also tell you to do is to make you feel thirst. Then you will feel the thirst and then you will go out to grab water. So you're driven by that osmolar receptor. In a way, it's like you are pushing to drink water. And that way we can retain more water in the body and to reduce that thick blood condition to make the osmolar receptor, osmolarity become normal. The thing in our society right now, so this is the ideal. Our body will maintain our blood osmolarity through this two pathway. But the thing happens in our society is that when you are thirsty, right, your osmolar receptor tell you that you are thirsty. What you do? You go to the store, you get sugar water, you get beer, you get something, but not pure water. And when you drink that into your body, you actually didn't really help because you are taking another thick fluid into your body and you actually didn't reduce the osmolarity in the blood. So the more you drink it, the higher density in your blood will happen. You retain more fluid in the body, you gain hypertension because that fluid in the body will cause the more venous return, more blood pressure, you gain hypertension, you gain the higher blood pressure, and you don't really solve the problem. Then you also drink more because your blood is still very thick, and you keep drinking, but you didn't really solve the problem. So that's the condition. That's not good. So when you feel thirsty, don't drink sugar water, don't drink something else, just drink pure water, okay? So you learn something, it's good for your health. All right, so that's the ADH. The other one is the aldosterone. It's driven by the angiotensin 2, acts on the adrenal cortex, adrenal glands. Adrenal gland has two portions, cortex and the medulla. In the cortex, it will release aldosterone, acts on the kidney to reabsorb sodium. So here is the adrenal glands. We have the adrenal medulla. This one releases epinephrine, norepinephrine. So this is part of the sympathetic nerve system. This adrenal cortex is the region that has three zones. One of it is the major hormone released from the adrenal cortex is cortisol, but it also releases aldosterone here. It has three zones. Glomerulosa release aldosterone, fasciculata release cortisol, reticularis release androgen. So this is a sex hormone. So this one, glomerulosa zone, glomerulosa release aldosterone is from here. And that will flow around to the kidney to cause sodium retention. So that's how we regulate our blood pressure, how we regulate our cardiovascular system through the autonomic nerve system and also hormone. The major hormone is the angiotensin 2, and that leads to two other hormones, ADH and aldosterone. All right. So you have the concept, you have the idea, you have the knowledge that how our body function in terms of the cardiovascular system. And I think this is the last slide. I want to let you know that cardiovascular system is so important to affect our health. The heart disease, the vessel disease, the atherosclerosis probably is the major cause of death in our society. It causes heart disease. That's the #1 cause of death in our society. It causes a stroke in the brain. That's #4 leading cause of the death in our society. So the healthy vessel is very important. The healthy vessel is not so good in our society. It's because that we have higher prevalence in hypertension and diabetes. Here we didn't really talk about the diabetes, but we talk about the hypertension. And the cause of hypertension is also very common. We have the stress life. So sympathetic nerve basically is acting all the time, unless you're sleeping. We have high salt diet that cause water retention in our body that make the condition even worse. Oh man. Yes. Sure. Yes, I will do it. I'm actually in the class right now. But yeah, I will do it. All right, thank you. Yeah, bye-bye. Okay. So here I show you that the prevalence of hypertension is very high in our society. And one thing you need to know is that because hypertension doesn't really make a person feel sick. So people, here is showing you that almost only half of the population, of those who have hypertension, have really managed it. And so we need to have that awareness that in our family, in our friends, we need to have that awareness that you need to really pay attention on this condition and to have good management in your health. All right, so this is the last slide that very important equations, stroke volume each time that blood pump out of the heart, cardiac output equal to stroke volume times heart rate, BP equals still times TPR. All right, thank you so much.